Why should we focus on the geriatric patient? Let me start out with a story. I was working a couple years ago and got to see a patient after his second visit to the ER that day. He had initially come in, had a ground level fall, came in, was evaluated, everything looked good. They said, hey, you can go home. His daughter came, picked him up, took him home, and then he couldn't get out of the car and he couldn't walk. So the daughter took him right back and said, hey, my dad can't walk. We did some further evaluation and found that he had a hip fracture. This is not a commentary on what happened in the ER at all, but this is more of a commentary on our geriatric population. These can be very tricky patients to care for. They have a lot of comorbidities, and then as we age, this particular patient had developed some cognitive impairment. He had some dementia, and he wasn't able to communicate that he hurt. And so it was very tricky for us that were evaluating him to know that there was a problem. It wasn't until his daughter had taken him home. And so I'm hoping with this, as we talk briefly about this topic, that I can provide you with a few tools that will help you in evaluating these patients to provide safe care and better outcomes. So there's a number of factors that account for higher rates of adverse events. About 1/3 of elective surgeries are performed on older adults. This proportion increases as the population ages. Older adults have higher rates of postoperative complications, readmissions, mortality, longer lengths of stay, and are more frequently discharged to post-acute care facilities compared to adults under the age of 65. A number of factors account for these higher rates of adverse events. Aging leads to a shift in expressed cytokines, producing a pro-inflammatory state that can increase the risk of postoperative complications, such as venous thromboembolism and stroke. They can experience worsened postoperative pain, muscle loss, and fatigue. Additionally, organ systems functioning diminishes, leading to an increased risk of complications. As you know, older adults also are likely to suffer from polypharmacy. Nearly 40% of adults over age 65 are on 5 or more prescription medications. Polypharmacy is associated with increased rates of non-adherence, medication errors, postoperative delirium, and drug-drug interactions. In a study of over 260,000 older adults undergoing elective, non-cardiac surgery, investigators found polypharmacy to be associated with increased postoperative mortality. I saw another patient recently, this was about a year ago, who came in with a hip fracture. This time it was diagnosed on the first visit. And I was asked to come and do a geriatric consult. So I saw the patient, and she'd been falling at home. She'd complaining of some ongoing dizziness. And as I looked over her medication list, I saw benzodiazepine. I think she was on Valium. It was oxybutynin and amitriptyline. All three of these medications can cause side effects that contribute to dizziness and altered mental state in the elderly. So I was able to talk to her family, put her on a taper, and by the time she left the hospital, she was feeling much better. There are numerous cognitive and psychosocial factors that also affect postoperative outcomes. Studies have shown that adults over the age of 65 have lower health literacy than younger adults. Cognitive impairment increases risk of postoperative delirium and inability to follow postoperative care instructions. Functional and sensory deficits impair ability for self-care after surgery. One study found that dependence in just one activity of daily living was associated with increased risk of postoperative mortality. Older adults also have higher rates of food insecurity, increased risk of malnutrition, and may suffer from social isolation, leading to inadequate support. So, a comprehensive geriatric assessment along with geriatric co-management successfully, 1, risk stratifies our patients to identify those at highest risk of complications. 2, improves postoperative outcomes. Collaborative models involving geriatrics, surgery, and anesthesiology, providing a multidisciplinary preoperative evaluation, can significantly decrease length of stay, readmission rates, and postoperative complication. Patients are also more likely to be discharged home rather than to a facility. The American College of Surgeons National Surgical Quality Improvement Program, ACS-NSQIP, and the American Geriatric Society have released best practice guidelines for perioperative care of the older adult. These guidelines emphasize assessing baseline functional status, screening for preoperative cognitive dysfunction, addressing polypharmacy, and modified goals of care discussions to reflect enhanced risk of complication. We advocate for preoperative evaluations in older adults, particularly for those at high risk of complications. For cognitive screening, there exist a few different tools to assist in identifying patients with impaired cognition. These include the MiniCog, which is the quickest, and the MoCA, which requires a little more time and some training to administer. Why does cognitive screening matter in these patients? We know that the vast majority of healthy, community-dwelling older adults have capacity for medical decision-making. However, rates of incapacity are much higher in patients living in facilities and those with cognitive impairment. In fact, one small study found that 18% of older adults presenting for elective surgery lacked the capacity to consent for their upcoming procedure. And a MoCA score of less than 19 was highly predictive of incapacity. So we as providers should be vigilant for possible diminished capacity. After performing a cognitive assessment, frailty screening is important in understanding a patient's overall risk. Frailty screening can be performed quickly in the office by using this tool here, the Clinical Fragility Scale, where we see that higher scores equal higher levels of risk. So very fit is a 1, terminally ill is a 9. In the original study where this fragility scale was developed, patients were followed for 5 years. And after 5 years, an analysis was done which determined the ability of the scale to predict death or to predict institutional need. Here we can see after 1 through 3, the scale of 1 through 3 is very similar, but after the third, if you go to 4, 5, and 6, the risk drops significantly. So on this scale, the medium-term risk of death drops by 21%. As you can see here, a score of 1 through 3, but as soon as you drop to a 4, 5, and 6, and 7, your risk of death is tremendously increased. Additionally, your risk increases at a level 4, 5, and 6 for institutionalized care. These were adjusted for age, sex, and education. So after frailty, we want to assess their nutrition. Nutrition screening can help identify patients who are malnourished or at risk of malnutrition. The MNA-SF tool allows clinicians to intervene earlier to provide adequate nutritional support, prevent further deterioration, and improve patient outcomes. For medication screening, an accurate and detailed medication history, considering any perioperative adjustments, review medications to identify those on the Beers list, which can easily be found online, discontinue high-risk medications such as benzodiazepines, decongestants, anticholinergics, analgesics, and muscle relaxants. Consider pharmacist referral and other specialists as needed. Once screening is done and the patient is optimized for surgery, we can then turn our attention to the postoperative recovery, which focuses on delirium prevention and functional recovery. At Utah Valley Hospital, where I work, we utilize an order set to help prevent postoperative delirium. This is shown here. These orders instruct nursing to manage the room's lighting to help patients stay oriented to day and night, hold IV fluids from 10 p.m. to 6 a.m., retime morning labs to 6 a.m., And these measures can improve sleep and minimize disruption. The orders also request nursing to provide sensory aids, such as glasses and hearing aids, as needed, and to monitor bowel movements. Finally, don't forget the importance of asking families to help with postoperative recovery. Families can do many things. They can engage the patient in cognitively stimulating activities, facilitate the use of sensory aids, encourage hydration and ambulation. In fact, we have found that even a program as simple as daily ambulation can reduce the need for discharge to rehabilitation facilities. So in summary, please consider assessing cognitive impairment, nutritional status, frailty, and reviewing their medication list for high-risk medications. Our geriatric patients deserve it. Thank you.